Hello everyone. At the outset, I would like to thank the organizers for such nice event. And in ETAPs, we keep seeing PRS dehiscence sometimes. We have been using barb suture for PRS closure for quite some time now. Recently, we had a barb suture from new company and we used it. And in two cases, we used it and we had PRS dehiscence. So I think it happened because of that particular barb sutures. Anyways, when I went on to see the video recordings again, I also made out that I have not used peritoneal bridges to my advantage. So I would like to share this experience with everyone, and I'll present these two cases. My case one. So this was a 50-year-old female who had an parabolical hernia. This is the surgical video. So the momentum was reduced, and we can see that this is an insufflation pressure of almost 14. Even at 14 pressure, the PRS could be brought closer easily. And this is the new barb suture which we have been using. But here, if I see, I have not used that peritoneal bridge properly and tried to approximate both the posterior rectus sheath edges. And this was at the end of the closure, and it is coming closely easily. And then when polypropylene mesh was used, and on second postoperative day, patient complained of some abdominal discomfort, not passing plateaus. So I did an CCT abdomen for this lady, and on seeing the CT, we could see that some small bowel loops are dilated, and when we went down and saw the CT carefully, there was a dehiscence in the posterior rectus sheath. So here is the dehiscence, we can see very well, and then interparietal hernia has occurred at this level. When we went in for re-laparoscopy, essentially the entry was lateral to semilunar line, as we have not done any TAR, and from there we can enter into the abdomen. And the entry was through open technique. So when we entered into the abdomen, we can see that there is a large gap in the PRS. That's why I say wherever I have taken that bites through that barb suture, it is cut through at all the places. So small bowel loops were adhered to the exposed mesh, and this is the barb suture bridge which is still there, and these are the small bowel loops adhered to the mesh, and gradually we reduced the small bowel loops and then divided this barbed suture. We can bring them down. So we assessed the defect. It was a large PRS defect, but the mesh was already sticking well to the anterior abdominal wall. So what we did, we tagged this defect. Then we planned to cover this defect with a dual mesh, and we used a 20 into 20 centimeter circular mesh to cover this defect. So this 20 to 20 centimeter mesh comes in, and what was important was that to center this mesh to the new PRS defect now. And while passing the suture passer, we have to support our mesh. And then like routine IPOM, this mesh was used and it was tagged again. So patient had two meshes and for post-operatively, patient had uneven full outcome, no seroma formation. And in 2 days' time, she became all right and was started orally and was discharged. So this concludes the first case. And again, the next day itself, I did one more surgery and used this barb suture again. And there was a 60-year-old female. She had a 3 into 3 centimeter umbilical hernia. On third POD, actually I discharged this patient on second POD. Patient was fine. On third post-operative day, she complained of pain in abdomen. So I did an CCT abdomen. So when I did the CCT abdomen, I could see that again in this lady, we had the same problem. Like the initial defect was just 3 into 3 centimeter, but when we see the CT abdomen, we can see there is a large gap in PRS. So it will come into picture now. So now here we can see there is a large gap in the posterior rectus sheath, and a lot of small bowel has herniated through this. So again, we discussed with the family that we have to do re-laparoscopy. So this time the patient and attenders, they refused the consent for using one more mesh. we could see that these small bowel loops are herniating through, and that the interparietal hernia can be seen here. So first entry was lateral to semilunar 9, and then other ports were placed under vision. And here we can see that momentum is sticking to the mesh there, and there's a large gap in the PRS. Here's the small bowel which has herniated and got stuck to the mesh. So again, one small bowel loop adhered to the mesh, and this was again reduced carefully. Since we went in on third day itself, again we had more or less no difficulty in doing the adhesive lysis. And here the small bowel loops was brought into the peritoneal cavity complete. Then now we can see there is a large gap which was not there at the first surgery. And then as discussed with the patient and attenders, we had very little options what to do. So we had to remove the mesh completely, and the mesh was brought out, and the posterior rectus sheath which was remaining there was tacked to the anti-abdominal wall. And basically this patient is now left with suture repair only. Two cases like what we learned that as we all have been doing, tension-free PRS closure is a must. We have been doing this, and wherever needed, we are using TAR for achieving this. What I have not done in first case was to use peritoneal bridge to my advantage. But nowadays I'm very careful, especially when I'm dissecting, especially in primary hernias, extraperitoneal dissection I do very carefully, and I save as much as peritoneum possible. And then one more point I would like to point out is that ideal suture material. So in my unit, I have completely stopped using any barbed suture for PRS closure. But yes, I've discussed it with many surgeons, and they are regularly using a barbed suture. So for me, any PRS closure is with simple suture now, and no barbed suture is used. And any patient, if we do E-TAPs, they are usually very comfortable, no complaints. But if a patient is having vague complaints, abdominal distension, not passing flutters, we should have high index of suspicion that something might have occurred. And at least a CT abdomen should be done wherever there is a doubt. And at least we can rule out there is no interparietal hernia. If we find something, early intervention is must. What are the various options? Like if we find an interparietal hernia, usually IPOM is a bailout technique for us. And sometimes we might have to remove mesh, as happened with me in this case. So with this, I'll complete my talk, and thanks once again. Thank you very much for your patient listening.